Hello.
You don't.
Okay.
Is it not able to see? And maybe we could just switch time silver.
Sehr Damen und Herren, ich heiße Sie herzlich willkommen zu der ersten Präsentation von unserer Global Health Vortragsreihe dieses Semester. Da unser heutiger Vortrag auf Englisch ist, werde auch ich im folgenden Englisch starten. Fragen können aber jederzeit auch auf Deutsch gestellt werden. Welcome to the first Global Health Lecture of the summer semester. My name is Virginia. I'm a PhD student at the Virology Department, and I'm also a member of the Global Health Society. I'm glad to introduce our guest speaker, Dr. Eva Berens. Eva completed her Bachelor in Health Communication at the University of Bielefeld. She worked as a research assistant for a couple of years with Professor Oliver Rathum at the same university by the Faculty of Public Health. And at the same time, she completed her master's degree in public health. And during the same period, she also studied in India as an exchange student at the Center of Social Medicine and Community Health in New Delhi. Back in Bielefeld, she completed her PhD at the Faculty of Public Health, and since 2015, she's a research associate at Working Group 6 Health Services Research, Nursing Science with Professor Doris Schiffer. Today, Eva will introduce a very interesting topic, aspects of health communication among migrants, health literacy, information sources, and disease awareness. Let's give Eva a warm welcome.
Thank you very much for inviting me to give this talk today. I'm not so familiar what your background is, so whenever you have a question in between, you're very welcome to ask. So, as you already heard from my CV, I have kind of two core elements or two core topics. One is migrant health issues, and the other aspect is communication issues. And today, I will put both together and present you an overview of issues that are relevant when it comes to health communication or communication in terms of health among migrants. That is a very broad topic, so I will not be able to cover everything in detail, but I want to put some highlights and maybe we can have a discussion when I've finished. So, why is it important to talk about health communication? There is a lot of change, especially in the German healthcare system, but also in other societies. More and more often, users and patients have more options in terms of therapy, decisions, in terms of their, well, they can decide which therapy they want to do, but they also should get involved in the decision. So 20 years ago, it was more like a what we call paternalistic view, so that the doctor said, patient, you should do this therapy, and the patient did it. But nowadays, patients should actively get involved in the decision for special treatment. So that's one thing. And on the other hand, our healthcare system is getting more and more complex through the various options we have, and also especially the German healthcare system, we have GPs and specialists and hospitals and this and that, and the patient has to navigate through this system. And we also have more information. So the technological change provides us with more information. We have, on one topic, we have different information from different sources, and patients need to check what information is appropriate, what information fits for my situation. And we also have digitalization. So in theory, information is easier to access than it was 20 years ago, because we just ask Dr. Google and get information on the topic, in theory. So that are certain things that make communication more and more important. So I picked out some topics related to health communication I want to talk about today. One is health literacy, so competencies to process health information. The other one is to talk about information material, so how is material designed, what information do they contain, and do we need to have something special with regard to migrants? Do they need different information? Then I also want to have a brief look at information sources in relation to migrants and on the aspect of interaction with migrants. Okay. Let me first start with the aspect of health literacy. That's a core element of health and health education. So what is health literacy? To give you an idea, I brought one very widely used definition that says that health literacy is linked to literacy, so reading and writing skills, and entails people's knowledge, motivations, and competencies, so these three things, to access, understand, appraise, and apply health information in order to make judgments and take decisions in everyday life concerning the healthcare, disease prevention, and health promotion. So, as you see, it's a very broad definition that covers different aspects, but that also highlights why communication or skills to process information are so relevant. I brought another picture. Health literacy can also be divided into three different aspects. One is, of course, the basis to process, so to understand its own health information, is that you have reading and writing skills. Without that, you cannot access, read, and so on information. But then you also have an interactive level, so that you actively participate and engage in information. You find and exchange and apply these information. And the highest level is critical health literacy, that you do not only find and use information, but you critically assess this information. To show you why health literacy is so important, I brought this model. I think it's a bit small in some parts, but as you see here, in the center we have knowledge, competence, and motivation to access, find, understand, appraise, and apply information. So these different phases of information processing in the fields of healthcare. So health information is not only relevant in healthcare, but also in prevention and health promotion. A very holistic public health view. But it also shows that health literacy is related to personal determinants, and that will bring me to migrants later on. And that's also very important. It is related to situational demands. where, how, which information are available. That is closely related to the chances or the abilities to process this information. And also, how are these information embedded in the healthcare system, and in which situation do I need or use these information? Is it that I get a diagnosis? Maybe I'm shocked. I have to read certain material for the first time for a very severe diagnosis, or is it I'm interested in breast cancer risk and I search for information? Do you know what I want to say? Does it become clear? So you may be forced to get involved with information on a certain topic, or you choose to get information on a certain topic. Okay, I don't know, some of you will work on migrant health maybe, but others may not. So I thought I brought a few numbers on migration in Germany, just as a brief introduction. In Germany, we have more than 18 million migrants. It's 1/5 of the population already. And about half of it has German citizenship, German nationality. And 2/3 have an own migration experience. Of course, this is changing over time. These numbers might not be actual in a few years because there are more second-generation migrants, but we don't know. As we have these new refugee waves, new migrants with own migration experience come to Germany. So we will not know how this will look like in a few years. So, but currently about 2/3 have an own migration experience. And currently the main countries of the region are Turkey, Poland, Syria. But that does not include the phenomenon of the Spätaussiedler, the resettlers, because they originate from different countries and are so-called ethnic Germans. Did I say that correct? Can you say ethnic Germans? Yeah. But in the statistics, you will not find them by country. Okay. And on average, migrants are younger than the average population, and they often have lower socioeconomic status. That is also very important to know when you talk about health issues. Why are migrants so special with regard to health? I brought a model from my former professor Eva Berens and Jakob Spalek. They put this model in a life course perspective, and I think that shows quite good why migrants are, well, special sounds not very good, but why their situation might be different from people in the host country, so in our case Germany, but also from people in their home country. So first of all of us start with genes when we are born. So that's what we bring. But then we have the situation in the sending society. So there are certain hygienic factors. The healthcare system plays a role. How are environmental factors in the countries? I know many of you work on issues in countries, for example, in Africa and so on. So all these factors are very, very, or might be different than in Germany. And that does not only affect health directly, but also health behavior. And then we have the process of migration. Why do you migrate? Is it forced, or do you want to go? Do you go alone? Can you bring your family? Issues like that. How do you start here? If you go because you want to for study, you start on a, let's say, different level, or with different aspects than if you're forced and you have to live in a refugee home, for example. And then you have the situation in the receiving society, for example, Germany. you have a certain social status compared to this society. Very important is the legal status. Do you have a residence permit or other forms that directly affects health and to which health services you have access? And of course, we also have an environment here. We have a special or certain healthcare system, hygiene, and so on and so forth. And of course, we have a different language here. And maybe different behavior, what people often call culture. When I always say, what is German culture? But things that cannot be measured, but life is different here than it is in the home country. Though you cannot say it's real culture, but you know what I mean? So, and then, and all these influences health and health behavior. And I think it becomes clear that there is not only the migrant. Migrants come from so many different countries. They're migrated as a child, as old persons, forced for study, and so on, or live here only for 5 years, for 30 years already. So a very diverse population we talk about. And I want you to keep this in mind because, of course, I will not be able to talk or to give results for all the different migrant subgroups. So I will talk about migrants, but I want to say that, of course, there is not the migrant. Okay. My results on health literacy will be based on 2 studies we conducted. One is a study on the general population, not have so many migrants in there, as you see. And we did that study in German, so migrants with very bad German language skills will not be included here. That's important to know. And this is a study especially among migrants and non-migrants, on adolescents with low educational level and on elderly migrants. I will mainly present the results from this study because the tendency is the same, so I don't have to separate for all the groups. But sometimes I refer to this other study so you should know the. Okay. So how did we assess health literacy? You saw this huge model and we had a very broad understanding of health literacy. So we looked at, do people perceive problems in accessing, understanding, processing, and applying health information in these 3 different fields? And there were several questions on each of these combined fields. What do we see in general? Can you see the colors? So older people perceive more problems processing health information than younger people do. There is no difference among men and women. That's very interesting because there is always a difference in health outcomes among men and women, but they don't perceive to a different proportion difficulties in processing health information. And persons with low education level also perceive more problems in processing health information. So far, not surprising. And in total, that's maybe also important, more than 50% in Germany perceive problems in processing health information. So it's an issue that's also relevant for the general population, not only a migrant-specific topic, actually. When it comes to migrants, we see that around 70% have inadequate or problematic levels of health literacy. That's far more than among persons without migration background. And when we look at the different topics, we see that especially in prevention and health promotion, migrants perceive problems in processing this information. Healthcare, of course, the percentage is also about 50% for healthcare, but the most difficult topics are health promotion and disease prevention. The tendency, by the way, is the same for non-migrants. Also for non-migrants, the field of health promotion is perceived the most difficult. When it comes to the different phases of information processing, we see that especially evaluating information is perceived very difficult. And I didn't bring the numbers, but for elderly, also finding is perceived very difficult. But also, again, the tendencies are the same for persons without migration background. We also see that age, chronic illness, social status, and educational level are associated with health literacy in this general study. And in the study where we could also ask migrants especially, and we have higher numbers, that the difference in health literacy is bigger among older people with and without migration background than among adolescents. So the gap is bigger among elderly. You have an idea what might be the reason for that among elderly or older people, this gap of limited health literacy is bigger? For example, that might be language problems, of course. I would, as you see here, social status and educational level play an important role among other, or educational level of the parents, I must say, play an important role among adolescents. So I presented because when we talk about communication, we may not only look at the target group itself, but also about persons relevant for this target group. And for adolescents, that's of course the parents. And we have number of school years and income among older people and language spoken at home, of course, for older people as a reason. So many adolescents have good German language skills, so there is not so much variation in the sample on that variable. Okay, so to conclude the topic of health literacy, we have a higher proportion of limited health literacy in general in Germany. So that's not a migrant-specific problem, but among migrants, the proportion is even higher. And processing information about health promotion is the most difficult, and finding and evaluating in special are perceived most difficult. But migration is not necessarily the reason for limited health literacy. That's often mixed with social determinants. So as migrants more often are of a lower educational level and lower social status, these might be the reasons that make the proportion of limited health literacy bigger, not the migration itself. But language is also very important. Okay. But it does not explain everything. Yeah.
One more question on that. For the first assessment, did you stratify on say educational background? So even if you like took it out of the equation, was migrant the status of being or not being a migrant still the like the significant factor for health literacy?
Yeah. Yes, it remained. So in the migrant sample, I don't remember the migrant background remains significant in the general sample, even when adjusting, for example, for education. And we also see that education plays a very important role when we only look at the migrant sample, and there we see that the effect of education is very, very high. So, but I cannot say which part of the proportion is explained by education, but it's a huge part.
It'd be interesting to see if say, an academic migrant still has a less health literacy
Yeah.
than an academic German.
You can, the concept of health literacy is very broad and does not only include the personal factors, but also, that's my next slide, the demands and complexity of the system. And interestingly, for Germans, as you may remember, the level of low health literacy or limited health literacy does not differ between medium and high education, only for low. So there might be factors that make or that contribute to the fact that persons with high educational level also perceive problems. And because we didn't give them a test, can you read these words? I think then you will see a clear relationship. But this is which information do I want to understand? So a person of low education level might be completely happy with very basic information and might not perceive so much problems in understanding these. But a person of high education level might want different information and perceive problems in processing this. So that's a bit tricky with this measurement instrument and education in the special case. Okay? Let me now come to information sources and information channels. Which information channels or sources are preferred among migrants? We don't need to go through all the different numbers, but what we can see here in general is that personal information sources are preferred. No surprise, and family plays an important role. Those of you involved in migrant health will know that family always plays an important role as an information source. What we can also see is that the internet is more important than amounts that might also be related to language issues, that you via the internet are able to find information or easier find information in your mother tongue, and that emergency units in hospitals are also a more important information source. Okay, specialists, by the way, are not used for information. So as often as I also brought an example from a study on mammography screening. So just to give you a brief background, every woman in Germany aged between 50 and 69 years is invited every second year for participation in a mammography screening program. And they get an invitation saying, you are kindly invited to perform mammography at this date in that screening unit. And they also attach an information leaflet. And I did a qualitative study and also asked women, how do you perceive receiving such an invitation letter? And some women said that a German authority is writing to me as a migrant and again wants something from me, as it was in the 60s when most of the working migrant rate occurred when many migrants came to Germany. So they had a lot of issues with official authorities. So was kind of a skeptical attitude towards receiving official letters concerning health issues. But there was also the opinion that, oh, it's so great, the state is caring about my health. So very different opinions. I just brought that to show you that the information source can be related with different perceptions due to the migration process and experiences made within that migration period. But it can also be very different, and they're happy that the state is caring and that the state is writing a letter to meet in person. But you see, the information channel is the invitation letter and the leaflet. But the information source for the woman may be husband or children, because women might not be able to read the letter on their own, as they themselves don't have enough German language skills to read it. So they receive it, give it to the children or husband. They filter the information containing that are in that leaflet and summarize the information, and maybe also give an opinion whether she should go or not. Okay.
Sorry, yeah, I just have a short question. It's on the idea of health literacy, because like in this case, for example, when we say that every woman aged plus 50 in Germany, like we are talking about like in brackets like German health literacy. This like because for example, I could imagine that in another country in which maybe this screening is not still out. This is not, I mean, I would not consider the woman in the situation to not be informed if something doesn't exist. So how do you kind of deal with these things? Is she considered as not having this literacy, or it's because she has it because in the country it just doesn't exist? Or for example, it's not in a country maybe it can be after 45 and in their country after 60. And then she tells you, yeah, it's after 60 and she did wrong, basically.
Yeah, that's what I meant by there are also system factors or external factors. In Germany, women are informed. So they have access to this information, theoretically, because every woman gets this and she's informed from this direct. In other countries, there is only opportunistic screening or no such invitation process. They have a selection of persons performing it because women do not know that it exists at all. So that's what I mean by the system factors that affect whether I'm able to understand, find information. So in this case, finding is not the issue because they get it. Yeah? So, but that's very different for different countries. And also these perceptions might be very different. It's very individualistic, but experiences made during the migration process might affect how women perceive the way information are spread.
Thank you so much. I have to go because I have okay,
Thank you. So when it comes to interaction, when we look at whether it happened that persons did not accurately understand explanations from different maybe health professions, it's not that much surprising that for most professions, migrants had already had problems in understanding. But it's interesting that it does not apply for all health professions. So some health professions might have a different understanding of the way they want or have to communicate with migrants. And the percentage of persons not understanding them is thus lower. Okay? But maybe they also have to communicate that much complex information.
How did you ask for that? So in an interview, because really, like with the health office, that's where I interact with migrants. So you exclude people who had never contact with the health office, or would they be in there? And,
No, they were excluded. So persons having had contact with, so it's not surprising that most persons have problems here because contact is much more frequent with these health professions or the health insurance than with the health office. But what you can also see, though the sum is not very big here, is, and that's I think special to health offices or to information centers, is that they have had from the beginning onwards a special focus on migrants. and special programs and so on and so forth. Okay, let me now come to information material. Which information have to be included and how do they need to be presented? So we have to think about information needs. And maybe they are different for migrants, maybe not. But let me again come to the example of mammography screening. In the qualitative interviews, there were many women saying, or the result was that women in tendency only seek medical advice when feeling pain. So the idea of prevention is not that much widespread. So a woman was saying, I currently do not go to the doctor because I don't have pain. So why should she go to perform mammography? There is nothing happening. So for these women, one could conclude maybe we need to explain a bit more about the idea why you should go to a doctor when you don't have any symptoms, maybe. But we also found that they have very different ideas about risk factors about breast cancer, and of course only on Turkish migrant women. So, but there are very different ideas about risk factors, treatment methods, prevalence, severity. For some women, it was very much influenced from their ideas from Turkey. So if you get breast cancer, you will die. So maybe when they migrated 20 years ago, there were no therapy options. So they kept that in mind and associate so breast cancer is a deadly disease. So maybe information needs to be a bit more, we need to give a bit more information on that than you would maybe need for other women. And they also named fatalistic belief in shame. But fatalistic beliefs does not mean if I pray I will get healthy. That's not the case. But if I get the disease and God or Allah makes me to have this disease, for me it's a task to fight. It's a task I've been given, so I have to do everything to fight. So it's not only the view that you have to accept because you think it's God-given, but also the fact that you may have to fight because of it. But these ideas or associations also often play a role. I didn't translate this file. I only want to highlight that. As you can see, these are information needs. How good or bad do you feel informed about certain topics? And you see that there is a difference in certain topics. For example, migrants feel a greater proportion of migrants feels bad or very badly informed about quality of nursing homes or about cost-related issues, about the health insurance. So there might be certain topics that are especially relevant for migrants, that are maybe not so interesting or relevant for the general population, might. So the information needs in general depend on the understanding of health and illness, the knowledge about the healthcare system, of course. What do I need to explain? Where's the basis where I start? Expectations about healthcare and expectations about information. Do they already know that they can decide whether they want to go? Or do they still have this paternalistic idea? I do everything my doctor says. Or should I explain that they have options to decide? And of course, personal attitudes and beliefs play an important role concerning information needs. Then, for those a bit familiar with epidemiology, I want to bring up another point. Which information are appropriate when it comes to evidence of, for example, screening? I again brought this example from mammography screening. On this side, we have information from the official information leaflet, and there is a flowchart saying there are 200 women. If 200 women participate a mammography screening program every 2 years for the 20-year period. At the end, 3 women will be diagnosed with breast cancer between screening rounds, and 10 women will be diagnosed with breast cancer in the screening. Those of you working in epidemiology will know that the performance of such tests is always related to risk prevalence. So sensitivity and specificity differ related to prevalence of the disease. So we did a hypothetical flow chart saying that for migrant women with a, let's say, 60% lower breast cancer risk, how would these numbers be? And it turns out that only 1.2 women will be diagnosed with breast cancer between the screening rounds, and only 4 women will be diagnosed with breast cancer in the screening. But the information women get is this. So maybe, I want to leave that open, information about evidence and the performance of tests also need to be adapted when we think about information material. But how do you at all detect whether there are inequalities related to information communication? Most outcomes are medical outcomes. Participation, mortality, performance or use of healthcare, but not issues related to communication. You can maybe suggest that persons you stratify for health status and so on and so forth, and they go to the doctor more and more often, that there might be problems related to understanding. But aspects of communication are not appropriately focused in statistics, if you ask me. So, of the test. And in Germany or in many other countries, such as the Netherlands, you see that migrants participate less often. You see, okay, there might be inequalities. We need to do interventions to make women participate in mammography screening. It should be equal. But that's a bit shortly thought in terms of mammography screening. In Germany, we don't have these differences between migrants and non-migrants in terms of participation. So you can say, okay, everything's fine. We don't have health inequality here. But for mammography screening, we talked about these information issues a lot. Mammography screening has both benefits and harms. You can have an overdiagnosis and so on. So you need to take other outcomes into account, such as informed choice, and the endpoint should not be participation. So that needs to be reflected also when searching for inequalities in health or communication. And when we look at the results, so you remember there were no big differences in participation on register-based data. But there is a big difference in informed choice. I go to this side. Only 5% of Turkish migrant women made an informed choice whether they want to go or not. For other migrants and the resetters, it was about 20%. So only slightly, 28.1% of German women made an informed choice. But I want to point out that you need to be sensitive for different aspects of detecting inequalities in terms of migrant health or where communication issues might be hidden. Okay, my take-home messages to adequately communicate about health with migrants, a plain translation of information using same information sources and so on does not work. It's not sufficient. You need to take into account their competencies, knowledge, and so on. So their health literacy need to deal with information, their information needs, which may be special or which may differ. Their preferred sources, putting an information at the specialist unit might not help because they don't go to the specialist that often, for example. And you also should take into account the risks, the disease risks they have. But migrants, as I showed at the beginning, are a very, very heterogeneous group. And most of the factors, when we talk about communication with migrants, are already solved when you define or accept or understand communication as an individualistic issue. So if doctors say, I don't judge groups, but I always reflect who is the individual sitting in front of me, or for whom am I creating information. A lot of problems are already addressed and solved because many problems are not only migrant specific. Also in the general population, people have different information needs and prefer different sources. Okay, thank you very much.
Thank you so much. So, is there any more questions?
Yes. Sorry, what different regulations and migrants in about like health insurance and stuff like that? So,
If you have a legal permission, there is no restriction. But for refugees and asylum seekers, they apply special rules. But I'm not very familiar about all the details. Is there anyone doing research on refugees here? I know there are some colleagues in Heidelberg working on that topic. So that's not my area of expertise, the exact difference in regulations. But there are, for example, doctors going to the refugee homes, treating people there, so they are not in the normal system in that way.
but then I have to be afraid to like pay more some to someone to go to the doctor.
Any more questions? I have a question actually, because I'm not really familiar with this topic. If we go back to the last slide, yeah, I'm wondering why this is actually happening, that Turkish women they have this less informative choice. Which could be the reason?
Yeah, that's partly a methodological issue. First of all, we know that Turkish migrant women aged 50 and above often have language problems. And that study had a focus on Turkish migrants. So we had a questionnaire in German and in Turkish. So we reached more Turkish women with bad German language skills, but for the other migrant groups, we only reached the women with quite good German language skills. So that might explain some of this low percentage.
Yeah, because if I understood correctly, you said the participation should be equal, right?
No, participation is irrelevant in that context because for mammography screening, because it has positive and negative effects, every woman should decide whether she wants to go or not. You can, for other things, maybe such as going to the dentist for control, you could say that should be equal. It's a good thing to have that controlled. So nothing happens in that. But for mammography screening, there are certain possible negative effects related to participation. So they could detect a very, very tiny breast cancer or pre-breast cancer stage that will never cause problems, but you will get treated. So that are things that women should reflect before deciding whether to go or not. A very, very complex field. That's why it's not surprising that even among German women, the percentage of informed choice is so low as well. Yeah?
Because to me, I mean, the benefits would be anyway more than these
But that's why attitude is also a very important aspect of informed choice, because attitude of the woman is respected, but attitude should be related to their intention to perform. So, because if a woman has a positive attitude and thinks mammography screening is a very, very good thing, and she wants to go, or she should want to go. But if she has a good attitude and she does not go, there are reasons lying in between that hinder the woman in going, and that's also an aspect of where you could detect inequality. Yeah?
And how do you think we could somehow implement this kind of information, like for example, in this specific case? Because I guess, as you said, women they receive a letter form with their leaflet where it is explained that they're gonna be tested.
Yeah.
But how do you think this could be implemented if it's not sufficient that they get this written information?
Yeah. So the information has been revised, so it now looks different, it has more pictures and so on, because other studies also found that it's very difficult to understand. So, so they already did that. But I want to come back to the fact that a letter is sent at all. I think the reason why there is no inequality in participation is that the letter is sent and every woman is informed. So there is no knowledge gap about the existence of the program as such, which is the case for many other healthcare issues. So it might be an idea to also have more official information that has for other health programs as well, to just inform about the existence. And then the complicated issues about pros and cons, that I think that's a different question. Yeah.
On this question, how do you recruit those migrants? I mean, they are not really labeled and they are scattered all around the society. How do you find them from the study?
We identified, for example, Turkish migrants by name-based algorithm. We did a poster questionnaire, and names of Turkish women have a meaning in Turkish language. So you can identify a Turkish woman, so we could send them a Turkish questionnaire. But we identified, it was just a representative sample we took from the registers, yeah. And then we asked the women, where were you born?
So basically, it's based on their Korean name.
That was just when, like, how we decided in which language we will send the questionnaire. But the information included here is based on self-assessed country of birth. Women saying, I was born in Turkey were labeled as Turkish.
So basically, you were sending those questionnaires also to Germans.
Yes.
Yeah, so,
Those are the non-immigrants. So we can, we send it to a sample or a general sample of women aged 50 years. Yeah. And then stratified in our analysis, not only.
And that was on the example of mammography screening, which is for women. Did you also do something for men? Or?
No, that was a study on women, because the unique thing is that they have this invitation system. They are currently planning to have invitation systems for other programs as well. But at that time, it was the only invitational program, and that was why I thought that's such an interesting topic, also to look at participation. What does an invitation system do with participation rates? But then if you look into detail, on what basis do they participate? Is it informed or not?
Any more questions?
Okay.
Just a little bit of clarification. Sorry, I came late. The questionnaire was in Turkish for the Turkish women or in German?
we sent them both versions. They could choose whether they want to answer the German or the Turkish version.
Because earlier you said you met many Turkish women with bad German, sort of when you were trying to explain.
That's why that was a qualitative study, but that's why we decided to have a questionnaire in Turkish for the Turkish women, because we know that otherwise we would have lost actually the most interesting group, but we didn't have planning to do a translation for other languages as well, and you cannot post a questionnaire in 10 different languages to all the women, so we had to focus on a certain group, unfortunately. Yeah.
And then a little clarification to the question she asked earlier regarding how immigrants seek health care. So I don't know, you said the doctors follow them to their residences or something. I don't know whether that was specifically for this study or that is a general practice.
No, the general, I didn't do a study on refugees, but I don't know if I understood you, but for refugee homes, I think there are doctors coming to us, special doctors, I think mainly coming to the refugee homes or doctors where they go. But in very rural areas, if I remember that right, they get such a paper where they can get basic care, I think.
I think that's not a rule that doctors always go.
No, it's for refugee homes especially, but not for migrants. That's a special case for refugees before they get their legal status, whether they are accepted to stay here or not. Just for that phase, during they live in these special forms, or whether they're during in that stage where their status is not clear. Actually. Yeah.
Okay, thank you so much, and I would like to invite you to our next event. It's going to be a little bit different format. It's going to be a bigger event on the 5th of June, so it's a Tuesday, and it's going to be from 4 to 6 in the afternoon, and it's going to take place in the Martinius College, and we will have 2 speakers and a round table afterwards where the audience is welcome to participate in the discussion. Thank you so much for your participation, and I hope to see you next time.
Ich mache den Wahlvertrag Global Health und dafür bräuchte muss ich eigentlich irgendwas unterschreiben hier, weil ich kann mir das anwenden. Deswegen ist online steht auch, dass diese Global Health Lecture Series als Wahlfach anwenden wäre.
Ja, das ist
Dafür müsste ich ja eigentlich irgendwas unterschreiben.
Und wer ist da verantwortlich, dass das in den Wahlvertrag dann reinkommt? Also, ja, gerne. Ja, das gehört ja eigentlich zum Wahlvertrag auch dazu. Und das muss ja am Ende irgendwie offiziell uns da dann den Schreiben ein Mail zu uns und dann wird das natürlich. Genau, also wir können nicht, wenn du nicht unterschreiben. Aber